So thanks very much to the organisers for inviting me to try to answer this question, why does PrEP have to be so complicated? Since WHO recommended recommendations in 2015 about PrEP as part of a comprehensive HIV prevention package, we've seen enormous efforts to scale up PrEP globally. And as of Q1 2024, there have been almost 7 million initiations worldwide. And we have also started to see the introduction of more PrEP options, including the dapivirine ring and injectable cabotegravir international programs, particularly in Eastern and Southern Africa, where the burden of HIV is high. But access has been uneven, and there is a way to go to meet the Prevention 2025 goals of ensuring availability of PrEP for 10 million people at substantial risk of HIV by 2025. The antiretroviral treatment program has really paved the way when it comes to thinking about simplification of PrEP. In low and middle income countries, upwards of 90% of people are on a daily fixed dose combination oral pill. Accelerated by the availability of TLD, HIV treatment programs have adopted and implemented differentiated service delivery models. Rather than a one-size-fits-all approach, those that are clinically suppressed or established on ART are eligible to receive refills in settings that are separate from the clinical consultation, and ART refills have been extended to 3 to 6 monthly intervals. For example, in South Africa, where I'm from, about 1.45 million people receive their antiretroviral refills outside of healthcare facilities and closer to home through community-based ART clubs. In this meta-analysis that's presented on the slide, community-based ART resulted in higher ART uptake, higher retention, and greater viral suppression at 1 year compared to facility-based ART initiation and refills. In response to COVID-19, adaptations to PrEP service delivery resulted in increased flexibility with trends towards demedicalization, simplification, and integration within other healthcare services, provision of virtual support, and differentiated service delivery for PrEP that aligned with client preferences. An analysis of the PEPFAR program monitoring indicators in 21 countries showed that PEPFAR programs continue to maintain and initiate new clients despite the challenges posed by the pandemic. As a result of adaptations in service delivery, the number of people on oral PrEP globally actually doubled between 2020 and 2021, from 800,000 to 1.6 million. And here you can see the same sort of trajectory in the example of South Africa. And these data have really suggested that differentiated service delivery models have the potential to increase PrEP access. So in 2022, WHO issued guidance on differentiated PrEP service delivery. And for those of you who may be less familiar, differentiated service delivery approaches consider the building blocks of who, where, when, and what of service delivery, and adapts these to really meet the needs and expectations of clients while acknowledging the constraints within the health system. In a differentiated service delivery model for PrEP, the who really becomes the PrEP user who may implement self-care approaches and only engage with the healthcare system for clinic visits. When reflects service frequency, and increasingly there are efforts to extend the intervals between clinic visits, particularly as many people using PrEP are healthy individuals, and this frees up clinic time to focus on consultations for those at greatest need of care. And then following the example of community-based ART, we've really seen a movement towards decentralized community-based locations for service delivery, including pharmacies, mobile vans, peer-led services, and motorbike deliveries to individuals at home. Finally, the what focuses on the minimum package of services required by PrEP users that includes streamlined monitoring and the opportunity for offering a package of sexual health services. And what I'm going to do in the remainder of this talk is focus on the what, the package of services. So PrEP should be offered to people without HIV, and one of the key elements to monitor has been HIV status to avoid monotherapy in the context of HIV infection, which could lead to resistance. So HIV self-testing can simplify PrEP delivery by increasing the interval between clinic visits from 3 to 6 months. And in this table is data from a study in Kenya where they looked at offering compared to standard of care HIV self-testing with 6-month PrEP dispensing. A number of these studies have been conducted, and a systematic review of 8 studies, including 3 trials, really found that HIV self-testing for PrEP continuation resulted in similar outcomes to standard of care delivery and was feasible and acceptable. And recently, WHO has recommended that self-testing be used to support clients during oral or ring PrEP initiation, restart or continuation. But there has been a little bit more caution around the use of self-testing in the context of long-acting PrEP agents. And this is because long-acting PrEP agents can alter responses to conventional diagnostics through viral suppressive effects that lead to delayed development of antibody responses and antibody detection, and so delayed diagnosis of HIV. And this has been described as the Levi syndrome, and the consequences of this really are prolonged long-acting PrEP monotherapy and the emergence of resistance. And this may have been one of the reasons that the FDA actually mandated HIV RNA testing as part of screening in the context of CAB-LA use. However, data at this conference has really highlighted some of the limitations of inclusion of HIV RNA testing into testing algorithms. And in this preliminary analysis, single isolated positive HIV results at sites performed poorly for detecting HIV infection with CAB-LA PrEP. And really, this doesn't surprise us because the prior probability of having an HIV infection on a long-acting agent is very low, and that prevalence is associated with a positive predictive value. But this is good news, particularly for low and middle-income country settings where it's probably infeasible to deliver HIV RNA testing. So the second setting where there has been additional caution has been the context of pregnancy, and many individuals of reproductive potential may want to use PrEP, particularly if they wish to conceive safely without the fear of HIV. And in the absence of reassuring data, some programs have really required pregnancy testing and interruption of PrEP during pregnancy. But fortunately, we now have data that provides reassurance that FTDF and the dapivirine ring are generally safe for use in pregnancy and lactation. And with respect to CAB-LA, the initial data really recognized that even if a drug is stopped at the time of pregnancy detection, the long PK tail means that pregnancies would be exposed to long-acting agents. And so many of the guidances focused on the idea of a risk-benefit discussion. But at this conference, we've seen new data that provides reassurance that CAB-LA use before and during pregnancy is generally safe for pregnant people and their infants. And this means that pregnancy testing is no longer required for safety monitoring purposes, and pregnant people can continue PrEP through pregnancy. So when oral PrEP programs started, there were concerns about the effects of FTDF on bone and renal health. And presented here are data from an individual patient data meta-analysis that included over 18,000 individuals from 15 countries. And what is striking is that in this analysis, less than 1% of individuals initiating oral PrEP had a baseline estimated creatinine clearance of less than 60 mils per minute. And in longitudinal follow-up, 2.43% of individuals had a decline to less than 60 mils per minute. What was observed is that higher risks were associated with increasing age and having pre-existing poor renal function. But the suggestion really is, based on some of these data, that the risks of kidney-related adverse events when using FTDF are, while they may be there, are generally mild and very small and really restricted to a much smaller subpopulation. So kidney function monitoring may be required for some individuals, such as those aged 50 years or older, and those with kidney-related comorbidities, but we really do not require, or we can make screening optional for younger populations and those kind of without renal comorbidities. And really the new implementation guidance suggests that we shouldn't make renal monitoring an obstacle to PrEP initiation. So I just wanted to call something out, and that is that a critical element of differentiated service delivery is that it is a person-centered approach and that it's aimed at simplifying services aligned to the preferences of the individual. So it's really important to remember that not everyone might want less engagement with healthcare services. And one example is really our experience of working with adolescents. In our experience, adolescent PrEP users, we've seen that PrEP persistence really declines with less frequent contact with healthcare providers. And in addition, in a study we did in Johannesburg, South Africa, aimed at providing PrEP to adolescents remotely in response to some of the COVID-19 restrictions, we found that some adolescents really expressed a preference for in-clinic visits because they were concerned about the lack of privacy at home. They had a fear about self-testing despite sort of significant support, and they also just had a fear about performing tests correctly without kind of adult or healthcare provider support. What we've also learned from the REACH study is that when we provide a menu of adherence options for adolescents that is customized to their preference, that leads to better adherence and persistence with PrEP. So this is really kind of a reminder that we need to remain person-centered when we're deciding on monitoring and the minimum package of services. Oops. So the last point is really that a key element of the PrEP package is the opportunity to offer a broader range of sexual and reproductive health services at visits as part of a one-stop shop approach. And this week, WHO released the new PrEP implementation tool. And in the tool, they recommend that these are some of the additional services that we should consider offering to a population based on population and context. This might include hepatitis screening, and this might influence the choice of PrEP, STI testing and treatment, although we should acknowledge that testing approaches vary across contexts, contraception for people who need it, and other services really relevant to the population, such as gender-affirming care, harm reduction services, or linkage to services for intimate partner violence. And while these services might provide benefit to PrEP users, they really also should not be a barrier, but rather provide an opportunity to enhance care by providing a person-centered service. So in summary, PrEP doesn't have to be complicated. And really, we should not let the perfect be the enemy of good if our goal is to provide PrEP to another 3 million people by next year. The evidence supports simplified monitoring and can accelerate access through differentiated service delivery. And simplifying monitoring potentially allows for better patient-centered care by reducing visit burden or creating time within consultations for additional services. So thanks to all of these people who in different ways have contributed to this talk.